Today, we'll be discussing the case of Jennifer Nibarger. Jennifer was somebody described as very loving. She worked as a pediatric nurse, she volunteered with health organizations, and she overall enjoyed spending time with her family and friends. Doing fun activities with her loved ones was something that she always looked forward to doing. That was, however, until one weekend boating accident left Jennifer in the hospital for weeks on end with several life-threatening injuries. After 7 weeks in the hospital, it was finally looking like she would be able to go home. But it was after doing one final test when they soon discovered something very wrong. And it was very soon after placing Jennifer in a different unit to get this treated when everything went left. There was something Jennifer's new care team didn't know about her case. And for several hours, as they thought they were effectively treating her, what they didn't realize was that Jennifer was slowly approaching cardiac failure. Following everything that happened, Jennifer's family looked into her case, and after reading through thousands of pages of her medical records, they would discover something in her charts that was truly unsettling. This case would reveal serious dangers of communication errors of a healthcare facility, and it emphasizes the importance of having systems in place to avoid something like this from happening ever again. But before we get into this case, just to introduce myself, my name is Petal Palmer, and on this channel I post anything medical, mysteries, and crime. If that is something that sounds interesting to you, please consider subscribing if you end up liking this video. All right, let's get into this case. Jennifer Nibarger was born Jennifer Kinker on Friday, January 13th, 1966 to parents Tom and Judy Kinker in Enochsburg, Indiana. She had 2 brothers and 2 sisters, and she was described as being very close with her siblings. Jennifer was a student at Batesville High School until she graduated in 1984. After graduating from high school, she went on to study nursing at the College of Mount St. Joseph, now known as Mount St. Joseph University in Cincinnati, Ohio. And a few years later, she would eventually graduate from this college with her Bachelor of Science in Nursing. It was from then on when Jennifer stayed in town, finding work as a registered nurse at the Children's Hospital in Cincinnati. She worked at the Children's Hospital for a few years, and after her time there, she would eventually work at United Healthcare. And a few years later, she then worked at a medical tech company called Medtronic from June 2001 to September 2009 before finding work as a territory manager at medical technology company Masimo Corporation. In her free time, Jennifer was an active volunteer with the Juvenile Diabetes Research Foundation, which is, quote, the leading global type 1 diabetes research and advocacy organization. Jennifer was a part of a pump support group. Regarding the work she did with this organization, one of the members of this group described her saying, quote, Jennifer was a great help to me whenever I had a question about my pump or needed an emergency supply. She was a beautiful and caring member of our pump support group. We all benefited from her knowledge and compassion. She made the world of diabetes a better place for all she came to know. Her loved ones described that Jennifer loved children, and they described that when she wasn't working or volunteering, she often enjoyed spending time with her nieces and nephews. She enjoyed entertaining, and she also enjoyed decorating for special events. In 2011, Jennifer had gotten married to a man named Brent Nibarger. With this, she became the stepmother of Brent's 3 sons, and she would eventually go on to have 1 step-granddaughter. Overall, she was the aunt to 14 nieces and nephews, and her husband described her stating, quote, she was 47 when this all occurred, prime of her life, prime of her career, prime of her health. One of Jennifer's co-workers at Medtronic described her saying, quote, Jennifer and I worked at Medtronic together in her 9 years with the company. I cherish the times I spent with Jennifer. She was kind, compassionate, hardworking, funny, and a joy to speak with. She went above and beyond to make sure patients with diabetes were taken care of. Many times, Jennifer eased the anxiety of parents whose child was recently diagnosed. When life gets chaotic and things aren't going quite the way I want, I will pause and think of Jennifer's positive attitude and kind advice she would give me all those years. Some more loved ones described Jennifer saying, quote, when I think of Jenny, I think of such a warm and beautiful person inside and out. Another person from Indiana described her saying, quote, I remember her coming to our house all of the time. She was always so nice to me. She was a beautiful person inside and out. Many describe Jennifer as having just a positive attitude and positive energy. They describe that she was very helpful in everything that she did. She would join groups. She did a lot of advocacy for type 1 diabetes. She did a lot of support. Many describe these characteristics about Jennifer. At some point in time, Jennifer ended up moving to Henderson, Nevada. This is a city about 16 miles southeast of Las Vegas. This was a perfect area for her because Henderson is surrounded by beautiful trails and beautiful lakes. Jennifer was described as enjoying doing activities like hiking, like going out on the boat on the water. And these were activities that Jennifer enjoyed doing with her family and with her loved ones. And doing activities like this were no different in September 2013 when she headed out with her loved ones to go out on their boat. On Saturday, September 21st, 2013, Jennifer and her husband Brent went out to Lake Mead for a day of boating. Lake Mead is the largest reservoir in the United States. Formed by the Hoover Dam on the Colorado River, it sits about 24 miles east of Las Vegas, and it provides water to the states of Arizona, California, and Nevada, and even to some areas of Mexico. Hoover Dam is a hydroelectric power plant located in Nevada. Constructed between 1931 to 1936, Hoover Dam remains a major tourist attraction in the United States. With the Hoover Dam bypass bridge spanning about 579 meters long and connecting both Nevada and Arizona, people are able to walk across from one end of the bridge to the other, getting a view of the dam below. It's known as the highest concrete arch gravity dam in the United States. But one thing that's also mentioned regarding the dam is the dark history of it. Hoover Dam was constructed during the Great Depression, which lasted from 1929 to 1939. While employment constructing the dam was some of the only work a lot of people could find at the time, it came with very severe conditions that people had to work in. During its construction, there had been several workers who passed away, and these were most notably as a result of accidents, illnesses, and even people who had taken their own lives. Just including cases of industrial fatalities, the official recorded number of fatalities is 96, and this refers to cases of things such as, quote, drowning, blasting, falling rocks or slides, falls from the canyon walls, being struck by heavy equipment, truck accidents, and more. However, despite this being the official recorded number, researchers say there were many more fatalities because this number doesn't include cases of fatalities from pneumonia, heart problems, or even weather, as well as just ones that just weren't recorded, period. Despite its dark history, however, they were eventually able to finish building the dam to not only be a significant source of hydroelectric power, but also a major tourist attraction, attracting around 7 million visitors per year. Through the Hoover Dam impounding the Colorado River behind it, Lake Mead was formed in 1935. And something that's interesting is that due to the rising of the water at Lake Mead in 1938, residents living in the community of St. Thomas, Nevada, were forced to leave their homes because of flooding. Today, St. Thomas still remains as a ghost town. However, Lake Mead remains a very important reservoir in the area. At maximum capacity, Lake Mead covers 247 square miles, and Lake Mead provides water for nearly 25 million people and many farms that rely on it. For the following recount of Jennifer's story, I'd recommend watching this interview her husband Brent did with the patient safety movement. I'd also recommend this article as he shared their story in his own words. The link for those will be in the description. On the Saturday of September 21st, 2013, Jennifer and her loved ones had a weekend of activities planned, which included spending time on their boat at Lake Mead at a nearby location. Lake Mead has several different launch ramps and marinas for people to spend the day boating, and it even has beaches for people to go swimming. They had gone to one of Lake Mead's marinas, and this was something they, like many others, have done and still do at these locations on the lake. As they were driving the boat on their way back towards the marina, they were trying to steer it. But as they were doing this, at some point, the steering on their boat had malfunctioned. This is a very dangerous situation because if the steering on a boat malfunctions and you're unable to control it, it can go in any direction toward anything. And as this was happening, their boat was moving in one direction, and this was toward a rock wall. And very quickly, as all of this was happening, they ended up colliding with the wall. This was a very serious crash. Everyone had suffered injuries, including Jennifer and Brent. However, the thing that was very concerning regarding Jennifer was that her injuries were very severe. Rather, they were life-threatening. Because as they had hit the wall, Jennifer was thrown forward and she crashed through the cabin door down to the lower gallery of the boat. From this crash, Jennifer had not only broken several bones, but she had head and neck trauma, and she also had external lacerations. Very quickly after this, emergency services were called, and Jennifer was subsequently airlifted to a level 1 trauma center. After arriving at the emergency department, Jennifer was assessed by the trauma team, and she was having difficulty breathing. Jennifer and Brent both spent the night in the hospital as patients. It was only that next day in the hospital when Brent, who too spent the night as mentioned, found out everything that was going on with Jennifer's breathing. And with how severe her condition was, they ended up placing Jennifer in a medically induced coma and placed her on life support. To properly support her during this coma, they placed a PEG tube in her abdomen, one to feed her nutrients, and they also placed something called a tracheostomy tube, also known as a trach airway or trach, in her neck to help her breathe. Jennifer stayed in this coma for the next 3 weeks, and while she was already dealing with very complex injuries from the boating accident, it was during this time another problem began to arise, because during her stay, Jennifer soon developed a few things called hospital-acquired conditions. Hospital-acquired conditions are complications that a patient could develop while inpatient at a hospital. Most notably, hospital-acquired infections or healthcare-associated infections are infections that can occur for patients during their stay. These aren't infections that are present during the time of admission to a hospital, but rather they are acquired after one is hospitalized and typically manifest about 48 hours after admission. And these can occur in any healthcare setting, including hospitals, long-term care facilities, and outpatient clinics. Not only are hospital-acquired conditions a significant cause of morbidity and mortality, but they also contribute to increased healthcare costs as they require additional care to treat in addition to the treatment the person was already doing for whatever they were in the hospital for. Pathogens can be transmitted in healthcare settings through a variety of channels, such as direct contact with healthcare workers or even the environment surrounding the patient. And some of the most common hospital-acquired infections include central line-associated bloodstream infections, catheter-associated urinary tract infections, surgical site infections, hospital-acquired pneumonia, ventilator-associated pneumonia, and bowel infections from bacteria. Some patients are more at risk than others. Most notably, some common risk factors include if they're immunocompromised, if they're older, or if they have any medical devices placed inside their body during the stay, like in this case, a trach and a PEG tube. Hospitals do take a number of steps to reduce hospital-acquired infections, but nonetheless, according to the CDC, quote, on any given day, about 1 in 31 hospital patients has at least one healthcare-associated infection. Jennifer had developed ventilator-associated pneumonia. She developed a urinary tract infection, and she developed a bloodstream infection. And while not mentioned exactly what they used, they likely administered antibiotics in order to treat these. After spending 4 weeks in the trauma unit, Jennifer slowly began regaining consciousness. She was now able to breathe on her own through the trach that she had in. And following this, she was then discharged from the trauma unit to instead be admitted at a long-term acute care facility. This is, quote, a specialty care hospital designed for patients with serious medical problems that require intense special treatment for an extended period of time. And it's stated that this is usually for 20 to 30 days. For the first couple of days in the long-term care facility, things appeared to be right on schedule with Jennifer's recovery. However, it was after the 3rd day in the facility when more complications arose for Jennifer, because she not only developed an infection at the surgical site of the trach in her neck, but she also developed an infection in her abdomen at the site of the PEG tube. Because of these infections, they had to discharge her from the facility and readmit her back into a community hospital. After spending just about 2 weeks in the community hospital, Jennifer's condition was looking much better. They had actually disconnected her from most of the tubes and lines she was connected to. She was able to move. She was able to go to the bathroom by herself. She was able to speak. She was able to write. And after getting nutrition in through the PEG tube for so long, she was looking forward to being able to eat soft foods again. Even though Jennifer was still breathing through the trach, she was able to breathe on her own without a ventilator. And she and Brent now were finally able to have a conversation with one another. Brent described that Jennifer wrote in big writing, quote, were gonna make it. And with how stable she was looking, the care team had begun planning for Jennifer to get discharged from the hospital. After 7 weeks of treatment and being admitted to 3 different healthcare facilities, Jennifer was told that she would be able to go home on the coming Wednesday morning. They told her, look, as part of your discharge, the next steps for you are going to be to receive physical rehabilitation assistance at home. And they just gave her information on the plan following her stay. Jennifer and her family were extremely excited to hear that after all of those weeks of treatment in multiple facilities, she'd finally be able to go home. But before any of that even happened, they told her that she needed to do one more thing, because before being discharged from the hospital, Jennifer needed to pass a routine test. And this was something called a barium swallow test. A barium swallow test, also known as an esophagram, is a radiographic study of the esophagus where the imaging is enhanced by the use of contrast. This test involves having the patient swallow a barium solution as a contrast agent while doing an X-ray in order to evaluate the structure and function and observe anything going on in their throat, esophagus, or upper GI tract. During these tests, a radiologist takes a series of X-ray images, and the patient may be asked to change positions during the test in order to get views from different angles. The barium solution that's swallowed for this test is typically thick and chalky. However, in some cases, a thinner barium solution may also be used. Overall, this is considered a quick and readily available diagnostic tool, and it's common, and it's often the first imaging study ordered to evaluate a wide range of problems with the esophagus. In this case, they wanted Jennifer to complete this test so they'd be able to determine if she could start eating soft foods again. This was the last thing Jennifer needed to do to be able to go home. And so on that Monday morning, they had Jennifer do this barium swallow test. While Jennifer was in position, she swallowed the barium, and the radiologist took the images while this happened. But it was very shortly later when something extremely strange happened. They observed the images and they noticed that the barium was somehow leaking out of Jennifer's esophagus and going right into her lungs. And this was when they found out Jennifer had something called a TEF. A tracheoesophageal fistula, or TEF, is a fistula or hole that forms between the trachea, which is the windpipe, and the esophagus, which is the food pipe. This fistula causes the two to be directly connected to one another, and this abnormal connection can allow food and liquid to pass from the esophagus into the trachea and lungs. This could lead to serious respiratory problems, including choking, coughing, and aspiration pneumonia. While TEFs are most commonly presented at birth as a congenital anomaly, TEFs are something that can also occur later in life as an acquired condition. Acquired TEFs can be caused from diseases such as esophageal cancer, lung cancer, infections such as tuberculosis, but it can also be caused from things like trauma, surgery, or even prolonged pressure from medical devices. The standard treatment for acquired TEF is to repair it through surgery. However, even after one completes a surgery, they still can experience later complications from it. It was while they did this test when they noticed that Jennifer had a TEF, because instead of the barium going down her esophagus like it should have, it went straight through her trachea, right into her lungs. Because of the barium going into her lungs, Jennifer began experiencing respiratory distress. Respiratory distress is a condition in which somebody has trouble breathing, often resulting in them showing signs, quote, that they are having to work harder to breathe or are not getting enough oxygen. This includes signs such as increased breathing rate, color changes, grunting, nose flaring, retractions, sweating, wheezing, and a forward-leaning body position. When somebody has a known or a suspected perforation, aka tear or hole, like a TEF, barium swallow tests are actually contraindicated because if there is a hole somewhere in this area and you swallow the barium, it could leak in places it wasn't intended to be in. Chen et al. Has stated, quote, barium swallow studies should be used in cases of suspected esophageal perforation only after considering the risk of inflammatory mediastinitis. This is not an absolute contraindication and should be weighed against the benefit of obtaining a timely diagnosis. While barium is generally preferred for these tests due to it having good contrast properties, it's still not suitable for all cases. In situations where there is a suspected perforation or acute chemical injury, like mentioned, it's recommended to instead use a water-soluble contrast agent such as gastrografin. In Jennifer's case, with the TEF, the barium in her lungs caused her to go into respiratory distress. And it was very clear that with this, Jennifer would not be able to go home in a couple of days. She needed to recover in the hospital. Her husband, Brent, described this moment saying, quote, "We'll never forget the day we had a conversation and I said, I can't believe we've climbed this mountain and we're at the top and ready to go home." For the next 3 days, Jennifer was transferred back and forth between multiple units and different caregivers, but her respiratory distress continued to get worse, and her team further continued to miss the signs that she was experiencing respiratory distress, because instead, Jennifer's team believed that these signs she was showing were as a result of anxiety, and because of this, they began treating her with multiple doses of Ativan. This is a benzodiazepine which is usually used to treat anxiety, but it's also used for other purposes. For example, in cancer patients experiencing chemotherapy-induced nausea. For Jennifer, however, neither of these were the case whatsoever, and this instead just complicated the situation regarding getting her the actual treatment she needed. Jennifer's respiratory distress was getting worse, and because of this, it was on that Tuesday afternoon when they decided they needed to transfer her back to the ICU. They called over to the ICU to see where they could place Jennifer, but to their dismay, there were no rooms available. So instead of bringing Jennifer to the ICU in a proper room, they now had to bring her to a room in a recovery area. While in there, her team discussed their next plan of care for her, and they decided that it would be a good idea to place Jennifer back on a ventilator through the existing trach she had in. There was a problem with this though. Because of the TEF, there was a hole in Jennifer's trachea. So when considering this, a concern should have been that with pumping in air for someone who has a TEF, depending on the position and the length of the tube, there's a possibility that the air wouldn't properly make it to Jennifer's lungs if it ends up escaping through the hole in her trachea to instead go where the abnormal connection is, which is the esophagus, aka your food pipe. But this is where the big problem was. The team members who decided to place her on a ventilator, in fact, didn't know that Jennifer had a TEF. They were not aware of the TEF that was discovered during the barium swallow test. So, because they didn't know any of this, they began ventilating her through the trach. And for the next 6 hours, they increased the cycle rate and oxygen concentration of her ventilation. The cycling of a mechanical ventilator refers to the change from inspiration, which is breathing in, and expiration, which is breathing out. To determine the cycle rate, they use a variable with a set value that must be reached in order to trigger the person to stop inhaling to then exhale. The cycle variables they can use to set this value are either pressure, time, volume, and flow. And this allows them to achieve a cycle rate referring to the number of cycles that occur within a minute. They were increasing Jennifer's cycle rate through this period. And in this case, the cycle rate for Jennifer reached 40 cycles per minute and the oxygen concentration reached 100% oxygen. Nobody from the care team performed any physical assessment on Jennifer. They didn't take any blood gases, nor did they monitor the amount of carbon dioxide she was breathing out. This value would refer to the end tidal carbon dioxide or end tidal CO2. And the reason it's important to monitor this is because depending on the amount of carbon dioxide she breathes out, This could give indications of whether her respiratory status is fine or not. Because gas exchange occurs in the lungs, when the end tidal CO2 is too low, this could indicate that there's a blood flow problem causing low circulation to the lungs and thus causing a low amount of carbon dioxide being diffused. However, if the end tidal CO2 is too high, this could indicate that somebody is experiencing respiratory distress or failure because it could show that too much carbon dioxide is accumulating in the lungs. They weren't monitoring these values for Jennifer, and the whole time as they had this ventilator pumping air into her body, what they didn't know was that this air was not actually reaching Jennifer's lungs, because instead, the air that was being pumped into her body was going straight through the TEF hole into her esophagus and down to her stomach. And because of this, Jennifer's lungs were receiving barely any oxygen. For the next 6 hours, as they continued increasing the cycle rate and oxygen concentration levels, Jennifer was barely getting any of this into her lungs. And she was very quickly approaching respiratory arrest. Jennifer's body and organs were very deprived of oxygen, and early that Wednesday morning at 12:04 a.m., Jennifer's organs and heart shut down and she went into full cardiac arrest. After she went into cardiac arrest, a code blue was called and staff members began rushing into her room. They performed CPR on her, but 1 minute went by, then 2 minutes, then 3, for a total of 14 minutes going by of Jennifer being in cardiac arrest before her heartbeat was restored. As the Code Blue team observed Jennifer's body, they realized that her belly was extended to 4 times its normal size. And this was because of all the air that they were pumping that went through the TEF into her esophagus and stomach. Because of this, they began performing an emergency pressure relief through her abdomen. Additionally, they also removed the trach that she had in and they intubated her, this time using a longer endotracheal or ET tube, thus isolating the TEF from her lungs to actually get the air to reach inside properly. Although they now made all these efforts to stabilize Jennifer, with how long her body had not been receiving oxygen, her brain had been deprived of so much oxygen and glucose that the damage at that point was far too much to recover from. Jennifer was unresponsive, and for the next 3 weeks, they kept her alive on life support. During these 3 weeks, they did multiple tests, scans, and neurological consults on her, but from each of these tests, they got the same results over and over again. Jennifer had suffered, quote, massive and non-recoverable brain damage. Brent and Jennifer's family just had to witness the state she was in, and it got to a point where there was no more hope that Jennifer would recover. From how extensive the damage to her brain was, they wouldn't have been able to reverse this, and eventually it was decided that Jennifer would be taken off of life support. On Tuesday, November 19th, 2013, they discontinued the life support, and shortly after, Jennifer passed away. It was about a week and a half after she passed away on Saturday, November 30th, 2013, when they held a funeral for Jennifer over in Enochsburg, Indiana, the community she was born in. Everything that happened at the hospital rightfully was weighing on Brent's mind, and he very clearly recognized the multiple deficiencies that occurred at the hospital. Brent stated that he didn't believe that the harm done to Jennifer from her caregivers was done intentionally. He rather described, quote, it's just a case of they didn't know. And he further emphasized were the multiple issues regarding improper medical communication handoffs and lack of organization and coordination that resulted in Jennifer passing away. A medical handoff is defined as the transfer of responsibility for a patient from one healthcare provider or team to another. A medical handoff occurs under a variety of situations. While a change in shift does require a shift-to-shift handoff, a medical handoff also refers to a patient being handed over to a whole nother department. Handoffs are very important in making sure that care and safety of the patient are properly continued. This is a period where all aspects of the patient's care should be reported to the next physician and care team. And for a handoff to be successful, it requires that the teams have effective communication and verification and documentation of the patient's care. Otherwise, without these, it could lead to very serious adverse events like in this case. One of the most critical times in Jennifer's care was during the period when she was transferred back and forth between multiple units and caregivers. She was experiencing respiratory distress from the barium leaking into her lungs. But for some reason, they misdiagnosed this as anxiety. And this just added further complications to the situation because they weren't treating her during this period for respiratory distress. They were treating her for anxiety, which are two different things. Brent stated that Jennifer's medical records were 4,661 pages long. But for some reason, only one paragraph in her medical records mentioned the TEF. Had they known about the TEF, they would have recognized that they needed to use a longer tube, for example, as mentioned, the endotracheal tube they ended up using after the fact. This communication error in itself was already a problem, but to further add to this, all the while they had Jennifer on this ventilator for 6 hours, for some reason, they were not monitoring her effectively at all. No one performed any physical assessments, no one took blood gases, no one even conducted end-tidal CO2 monitoring. And had they did, they would have been able to recognize that Jennifer was not getting enough oxygen sent to her body. It's been reported that a common root cause of serious medical errors in healthcare facilities are communication failures. A sentinel event refers to, quote, a patient safety event that results in death, permanent harm, or severe temporary harm. The Joint Commission reported from 2022 that amongst 1,441 sentinel events that occurred at healthcare facilities, failures in communications was one of the 3 leading causes. Even in 2015, they reported communication as the 3rd leading factor. According to Blazin et al., approximately half of these communication failures occur during patient handoffs. And in a June 21st, 2020 article referencing Jennifer's case, Jean-Marie Saver, a medical legal nurse consultant, cited statistics showing that from 2011 to 2016, 1,744 fatalities were caused by improper handoffs, and these resulted in approximately $1.7 billion in malpractice lawsuits. There are many tools and structured patient handoff protocols that care teams can use to ensure there's not a gap in communication that can lead to such a tragedy like this. For example, there's a tool called iPass, and this is a structured, evidence-based handoff tool in ensuring handoffs are conducted effectively. The iPass mnemonic represents 5 components of a quality patient handoff. I is for illness severity, which is a one-word summary of the patient's condition of either stable, watcher, or unstable. P is patient summary, which is a brief synopsis of the patient's diagnosis and treatment plan. A is action list, which details the tasks that needs to be done by the clinician receiving the handoff. The first S is situation awareness and contingency plans, which provides instructions in case of changes in the patient's status. And the next S is synthesis by the receiver, which is meant to give the receiver the opportunity to ask questions and confirm the plan of care. The iPass format is widely regarded as the gold standard for effective sign-out communication between physicians. It's also been shown to improve the quality of nursing handoffs, and it has been evidently shown to significantly reduce medical errors and preventable adverse events, in turn improving patient safety. Sometime between 2017 and 2019, a quality improvement initiative was conducted at St. Jude Children's Research Hospital in order to adapt, implement, and sustain iPass across various scenarios in which handoffs would happen. In this initiative, they looked at 3 handoff scenarios. 1, evening shift to night shift physician sign-out. 2, morning and evening inpatient nursing bedside report. And 3, handoffs when admitted patients were temporarily transferred to diagnostic imaging or procedure departments. They found that with iPass, error rates in the hospital were significantly reduced. Before iPass was implemented, the mean number of perceived handoff errors per handoff encounter for inpatient nursing was 0.42 errors per handoff. But at weeks 8, 16, and 24 after implementation, the mean number decreased to 0.06, 0.19, and 0.13 respectively. Additionally, inpatient nurses, physicians, diagnostic imaging technologists, and procedures nurses all reported improvement in their perceived personal handoff effectiveness after iPass was implemented. Likewise, a study by Stormer et al. In 2014 showed similar findings, that with standardizing handoffs through IPASS, there was a 23% reduction in medical errors and a 30% reduction in preventable adverse events amongst resident physicians at 9 pediatric hospitals. Likewise, in a later study in 2017 by Stormer et al., they demonstrated that the use of an IPASS nursing handoff bundle also improved communication quality and workflow. Another tool that's used is one called SBAR. This is a communication tool where S, the situation, describes what is happening at the moment. B, background, provides relevant patient history, background, or any relevant information. A, assessment, is how the clinician analyzes or interprets the situation. And R, recommendation, proposes the next steps or actions needed. The evidence of SBAR in improving transfer of information by itself is mixed. However, when paired with other safety interventions, a 2021 review has found that there were improvements in patient outcomes. On the Wednesday of January 6, 2006, the Joint Commission established a national patient safety goal addressing handoffs. And 4 years later, again on January 6, 2010, this was actually established as a provision of care standard, requiring that, quote, the organization's process for handoff communication provides for the opportunity for discussion between the giver and receiver of the patient, with the recommendation for them to be delivered face-to-face whenever possible. Jennifer's husband, Brent, also brought up the benefits of using different tools of the electronic health record, or EHR, specifically referencing something called the problem list, which is defined by the Centers for Medicare and Medicaid Services, or CMS, as, quote, a list of current and active diagnoses, as well as past diagnoses relevant to the current care of the patient, and which the Association of American Medical Colleges refers to as, quote, the primary list of a patient's clinical issues that is accessible in all care contexts. First defined and created in the 1960s by Dr. Lawrence Mead after being accepted as a component in paper medical records, the problem list eventually became a part of computerized systems required for providers to use. Now, problem lists are something that are manually filled out by providers. However, what Brent has mentioned, and also what a lot of studies have discussed as well, are the ideas of an automated problem list. Automation of problem lists through natural language processing is a topic that's been discussed for several years, as seen by this 2005 article, for example. In Brent's interview, he mentions the idea of a chronologically ordered computerized problem list. This problem list is one in which all of the patient's accumulated medical information is placed into a computer system, and this system ranks each problem from the most problematic or concerning issue at the top to the least problematic at the bottom. It's meant to be organized as a team effort by those providing care to a patient. Many studies have shown the merit in using automated programs, such as in this 2017 study, which concluded, quote, physicians are burdened with the task of assimilating vast amounts of information in the EHR systems. Despite spending a lot of time and effort, and despite their best intentions, they tend to miss important problems. The existing problem lists in patient records are inaccurate, and maintenance of the problem list is not currently a part of the physician workflow. An accurate problem list can have significant benefits, and a cognitive computing system which effectively models clinical thinking, including disease chronology, can automatically present problems for physicians to verify and validate. So essentially, while providers still, of course, have to create the problem list themselves, using these systems could be helpful in aiding anything they miss. As Brent reasoned that it's not humanly possible for one person to retain so much information on a case, especially one as complex as Jennifer's, during a time like a shift-to-shift handoff. So using this system could be a good way to make sure no issue slips through the cracks. The main concern with this is just trying to get around the concerns of, quote, redundancy and non-problems, which are challenges that can occur when using an automated system. Now, there are varying views on the effectiveness of the problem list amongst different providers, with the main concerns referring to issues concerning organization, as many have found issues with, quote, uncertainty about the responsibility for maintaining the problem list and little perceived benefits. And others have mentioned problems regarding the lack of the problem list being updated, with Dr. Erica Erica Reamer mentioning in a May 8, 2022 blog post the issue of providers, quote, not removing conditions that were placed on the problem list by a different provider. The American Academy of Family Physicians also mentions this, but further states, quote, the problem list can provide a useful snapshot of a patient's current health needs, but only if it's up to date and complete. Problems that are no longer active but still affect treatment can be given a history of designation and stay on the list. Problems that no longer affect treatment should be removed. In the aftermath of this case, these errors from the lack of communication shown by Jennifer's care team was something that also extended beyond Jennifer's stay. Because for 2 years following Jennifer's passing, nobody at the hospital reached out to her husband, Brent. Brent stated, quote, on November 19th, the decision was made to discontinue life support as there was no hope of reversing or recovering from the complexity and tragedy of these multiple medical communication handoff errors and acquired complications. To this day, over 2 years later, not a single person at the hospital has ever said a word to me about the death of my beautiful wife. And get this, just around the beginning of 2015, Brent contacted Jennifer's health insurance, Blue Cross Blue Shield, and it was only then, 1.5 years after Jennifer passed away, when Blue Cross Blue Shield found out that Jennifer had passed away from the hospital's errors. They had no idea about this until Brent had spoken to them. And this was something the insurance company found out after already paying $2.1 million in full to everyone involved in her case. What happened to Jennifer was completely avoidable, and what happened in this case truly just emphasizes the importance of ensuring effective communication is held between care teams. Jennifer should be remembered for the love it was described that she had, and her story should be remembered as a significant reminder of taking preventive measures, following standardized protocols, having thorough documentation, and just overall promoting a culture of open communication are very important factors in preventing tragedies like this from happening to somebody else. As Brent described, quote, consumers of healthcare have to be more aware of the inherent risk and dangers, and it is imperative, especially for the more complicated things, that you have a patient advocate. I'm really trying to do what I can to be an advocate, to be part of the change, and to use the story and all of its pain and emotion in a way that maybe will help. Through Brent speaking out about Jennifer's story, hopefully this can encourage hospitals and anyone working in healthcare to do their due diligence to communicate effectively on relevant information regarding their patients. Hopefully it can encourage healthcare facilities themselves to implement training and implement systems that are required to be followed. And hopefully it can also encourage patients to advocate for themselves and be aware of these issues that may occur. But yes, that is it for this case. What are your thoughts on this story? Please comment your thoughts below, and don't forget to subscribe so you don't miss any other videos on medical cases, crime, and mysteries. Bye now.